Today's webinar is Introduction to SIBO 3 Treatment Protocols and Personalizations by myself, Dr. Bradley Bush. A little bit about myself here. I'm a licensed naturopathic doctor. I am practicing at the Natural Medicine of Stillwater, which is an integrative medical clinic in beautiful Stillwater, Minnesota. And I have worked within the industry, both with laboratory testing companies, supplement companies for many years. I'm happily married to another naturopathic doctor, and I have 4 daughters. That's me. So, learning objectives. What are the attendees of this lecture going to take away? Well, you're going to be familiar with general SIBO treatment protocols. Learn to personalize treatment protocols based on breath test results. Understand prokinetics and when to use them, and how digestive support options to help reduce SIBO reoccurrence can be put into play. So, we've had some previous webinars. Both the Introduction to SIBO Part 1 and 2 is recorded and posted on our website. In addition to that, we also have one SIBO liver estrogen dominance connection webinar also posted at the www.neurovanna.com website. If you'd like to get copies of the slides or a copy of our treatment algorithm, feel free to contact your sales rep or contact our sales department directly, and they'll be happy to share that with you. Okay, your patients say I have SIBO, so what? So do they have to change your diet? When are they going to start feeling better? Do they have to take antibiotics? Is this a treatable or chronic issue? How do I avoid reoccurrences? And when do I retest? These are just some of many different questions your patients will present. And of course, once your patients think they have SIBO, they start Googling SIBO and they start reading everything. And there is a lot of information that is both good to help educate the patient and bad because a lot of information, as we know on the web, is recycled information. It doesn't necessarily mean it's always accurate information, or if it's rather intended purpose is to push people towards certain thoughts, treatment protocols, etc. So it's sort of a plus minus, and oftentimes, as with most conditions, fear-based medicine is often a tool used to scare people into doing treatment protocols that sometimes they don't need, or that they're told that the treatment is useless because SIBO's found in everybody. And of course, I don't really subscribe to either one of those train of thoughts. So here we go. So first off, what is SIBO? Well, as you can see from the illustrations here, SIBO has a lot to do with gas and bloating and other things that cause distension in the GI tract. Sometimes that distension is not always there. Sometimes it's just abdominal pain. SIBO defined as an excessive amount of bacteria in the small intestine. SIBO is a condition where colonic or mostly anaerobic bacteria that's normally found in the large intestines are found in significant populations in the small intestines, where they then ferment many different disaccharides. Classic symptoms of SIBO include the nausea, flatulence, bloating, diarrhea, halitosis, constipation, and malnutrition. But there's other symptoms that are not part of the classic symptom list that you should be aware of. This includes muscle weakness, joint pains, brain fog, anxiety, insomnia, headaches, GERD, neuropathy, skin rashes. What is the overall the breath testing process? Well, it's a simple 1 to 2 day prep diet, 12-hour fast overnight, followed by baseline tests, and then a sugar consumption of a sugar drink for the challenge aspect of the test, and then collection of the breath every 20 minutes for a total of a 3-hour long test, 10 breath collections, and this helps us then map out the GI tract for hydrogen and methane activity, both in the small intestine and in the large intestine. Now, if you are not familiar with the testing process or how to put people through the whole process to screen them and to test them, feel free to check out our webinars 1 and 2 in this series. Pre-test avoidance. Of course, there's a little wiggle room for some patients, and of course, you can always discuss when that time comes about. But in general, it's agreed that 4 weeks is the safest amount of time to avoid antibiotics and to do a breath test. For 2 weeks, it's avoidance of antifungals. 2 weeks after any surgeries, colonoscopies, enemas, or colonics. And we like to have 4-day avoidance of any laxatives. Now, of course, for some people, they'd say, if I don't do anything for 4 days, I'll be plugged up. I might have to go to the ER. Well, obviously, we don't want that to happen. So 2 days is for people with extreme constipation and you're afraid of some type of blockage. But in general, if you can get to a 4-day avoidance of laxatives, that would be ideal. And when we talk about laxatives, it just means anything that is going to help increase motility in a patient. That includes high doses of vitamin C, magnesium, probiotics, anything they may be taking that actually makes them go on a regular basis. Obviously, we want to test the person in their normal motility pattern, not in an altered one. And unfortunately, we have to mention that there's no smoking or secondhand smoke for at least 1 hour before the test. Otherwise, it will alter gas levels in the specimens. No sleeping or vigorous exercise for at least 1 hour before or at any time during the test. Prep diet, 2 days if the patient is constipated. Otherwise, it's just 1 day for everybody else. And you can have plain water, coffee, or tea, no sugar, artificial sweeteners, cream, or added, nothing. Baked or broiled chicken, fish, or turkey, plain steamed white rice, eggs, and they can have a clear chicken or beef broth. That means just meat broth, no bones or cartilage. And this is something that's nice to do if the person has to do a 2-day prep diet or they don't have a very good production of saliva. Neurovanna provides both test results and interpretations to help practitioners guide the patients through diagnosis of SIBO. Now, when we talk about treating SIBO, one of the things we always want to put in the back of our head is that we also want to look at what are the root causes for SIBO. So on the front side of things, you can look for anatomical defects that may be potentiating overgrowth. So anything that is obstructing proper movement, whether that be adhesions all throughout the abdominal cavity, bowel obstructions, fistulas, line loops, strictures, diverticula, and other ileocecal valve issues. There's also possible drugs that reduce intestinal motility, opioids, serotonin receptor antagonists, etc. Elimination of drugs that reduce gastric acidity, so antacids, hydrogen receptor antagonists, and proton pump inhibitors. All these might be considered initial reasons why people had SIBO in the first place, which you need to address so that when you treat them for SIBO, it just doesn't come back, or at least you're in the process. Like, for example, like with adhesions, this might be a long-term treatment process, and therefore at least you're working on it as you're managing the SIBO over the longer period of time. In addition to that, there's controlling diabetes and reversing some of the damage of diabetes, especially some gastroparesis that might have crept into the diabetic picture. And of course, then there's some things that integrative docs do really well, which is include ruling out hypothyroidism, both clinical and subclinical. Many times, people are on levothyroxine, and that leads to improper treatment. The patients oftentimes might not have enough active T3 hormone, and it leads to decline in motility, a very common reason why motility is reduced in patients, and that's an easy thing to identify and to treat with a patient. SIBO prevention, we're looking, and of course we're looking at prevention before in our heads along with treatments, because once again, you can knock down and knock out the bacteria, but if we're not treating why they had a problem in the first place, they're destined to repeat it over a period of time. So We like to try and make sure we keep this in the front of our mind. Gastric acid secretion. So give them some betaine HCl, do a betaine hydrochloric acid challenge test to see if they are producing stomach acid in proper quantities. If not, that could reduce gut motility, reduce gastric emptying, and increase the amount of bacteria being ingested with foods. Bitter herbs are also used. Sometimes if a person is graduating from betaine HCl and it becomes too caustic for them, so i.e. that they're starting to produce their own hydrochloric acid, bitter herbs can be used as the next step in general support, which are, of course, then the bitter herbs are also really good for mucolytic mucosal support. Intestinal motility agent, Prokinetics, which we'll discuss a little bit later in this lecture. Intact the ileocecal valve massage, manipulations or adjustments, depending on if you're a practitioner, if you're a chiropractor or a naturopath or an osteopath. Acupuncture. All these things can help with ileocecal valve dysfunction and can be incorporated. Immunoglobulins with intestinal secretion, so oral IgG or other immunoglobulin therapies, colostrum, and even L-Glutamine could all be used if the person's intestinal immune system is highly compromised, if their intestinal barrier defenses are highly compromised. These immunoglobulins are able to coat that GI tract and help in provide first-line defense for the intestinal barrier, which then helps you in the short term heal the patient. Bacteriostatic properties of pancreatic and biliary secretions. So, hey, you might need to add in some digestive enzymes, whether it be pancreatic or plant-based enzymes. In addition to that, you could also provide ox bile. And I find that about 50% of our SIBO patients often have relief with ox bile. Motility dysfunction. So you're looking at autoimmune conditions like systemic sclerosis, Parkinson's disease, which unfortunately gut motility issues go hand in hand with, diabetic neuropathies, post-radiation enteropathies, and ileocecal valve incontinence. All these things can also lead to function. So this is a copy of the treatment algorithm that I had done. I had taken the template that Cedars-Sinai, Dr. Pimental created originally in 2006, and then was updated with Dr. Seibecker and Sandberg-Lewis in 2014. I've now kind of updated it a little bit further into my own treatment protocols and observations and additional support items. So this particular PDF of this can be had if you want to contact our sales department. They're happy to share that with you, and I'm going to be using this treatment protocol to discuss the different treatment options. And part of it is that it all starts with the breath testing. Once you measure a patient's breath levels of hydrogen and methane gas, we can then start looking at how we want to address that. Because obviously, if they test and it's negative, then it goes back to a whole another type of lab workup to figure out what actually is going on. Likewise, there's dietary changes that will be incorporated with anyone with a positive, and this includes everything from a low FODMAP diet to a SIBO carbohydrate diet that Dr. Seibecker created. In addition to that, your patients may then choose one of three or combinations of treatment protocols, whether it be herbal therapies, elemental diet treatment, or prescriptive antibiotic therapies. So in that realm, there's going to be some variations due to whether or not it's a hydrogen dominant versus a methane dominant SIBO, and how they respond to treatment. All right, so let's kind of walk through some of this first. So in our treatment options, as I mentioned before, we have diet. Diet is going to help in controlling the SIBO activity, i.e. it's not going to fertilize the bacteria as you start treating it. This is always a very good idea. Some patients, they will be able to be strict on the diet for a short period of time. And of course, we like to encourage them throughout the entire treatment duration, which I think could be up to 8 weeks. We strongly encourage it. Sometimes, for those patients that cannot stick to a strict diet, we let them know that during any type of herbal antibiotic treatments, or of course during the elemental diet, the sticking to the strict diet is of utmost importance. During the antibiotic treatment protocols, if you choose to use those with patients, patients can be a little bit less restrictive on those, which of course then makes them somewhat more desirable in some cases. In the three therapies we have the elemental diet as one of the therapies, which is a liquid 2-week to 3-week diet, herbal antibiotics, and prescriptive antibiotics. These are our most well-researched and most clinically used approaches. There are some others, and I am doing a little bit of background research on some of them, including using live probiotics and different diets, rotating different diets with patients to see if that also changes it. Once again, what I'm going to discuss today are the three most well-used and published treatment protocols. So diet-wise, obviously, goal is to reduce food sources for bacteria, so limiting those fermentable carbohydrates, starches, and soluble fibers, not fibers, include soluble fibers, sugars, prebiotics, many different options that patients go into, from the paleo to the autoimmune protocol, the anti-inflammatory protocols. There's many different ones that people choose to use. I find the Dr. Sy Becker's guidelines that she has on her SIBOinfo.com are the most useful, the easiest to follow, and I have the most success with. So you can definitely use other variations of different FODMAPs, but at the same token, I find Dr. Sy Becker's to be the most inclusive and most successful clinically. Now, a couple of warnings though. Restricted diets can result in patient anxiety, and of course, in highly restricted diets over a period of time, you can actually cause an eating disorder in someone where it might have been lying a little bit underground, or hadn't eked its ugly head out yet. So we have to be careful. Many patients are told to be on restricted diets for years upon years, and as a practitioner, I don't like doing that. If they are having difficulty expanding their diet, that means there's something wrong that's not being addressed, typically, unless there's true allergies involved here. So ultimately, the patients that have to exist on a restricted diet means that I myself, or the doctor, is just not doing their full job. Nothing against the doctors, including myself. Try not to get down on myself, but sometimes that does happen with patients. But once again, living a life on restricted diet is not a good long-term strategy. And in addition to causing the anxiety and possible eating disorders, it also makes it more difficult to, in the future, expand the diet and to reach a truly good microbiome balance, because that restricted diet is also preventing the proper formation of healthy bacteria in the colon and possibly in the small intestine. So it also causes its own microbiome dysbioses. So warning sign with any patient with a history of an eating disorder, highly restricted diets may not be the best thing for them. Also, history of OCD or anxiety. That's a warning not only for restricted diets, but also in treatments, because you can definitely flare up the anxiety and OCD during treatment, like during the bacterial die-off, but also with the fear of food that can also be created. So always keeping that in the front of our minds. We want to help the person, not do harm. Benefits of dietary restrictions must be weighed against possible harms in each of these patients, and that's a case-by-case basis. So at sort of the heart of many of the treatments is the use of herbal antibiotics. And in the use of herbal antibiotics, there's a protocol that we have that's a base protocol for hydrogen dominant SIBO, and that's using an oregano oil product twice a day, usually morning and noon. We use berberines. I use 500 milligrams per capsule, 2 caps twice a day, morning and noon preferably. I like to use a Neem product. We get a traditional retail product that's an organic Neem, 500 milligrams per tablet per capsule, and it's 2 caps twice a day, morning and noon. We always tell patients that it's a minimum 2 weeks of herbal treatments before you start any prescriptive treatment. Or if there's not going to be any prescriptive antibiotics, a 4 to 6 week treatment period. So it's not a forever treatment protocol. We don't want people to be on it for 6 months because once again, these are very powerful herbals that kill a lot of different things. Good bacteria, good fungus, bad fungus. And they can also be a little caustic and irritating to the tissues. So if you find out that you're needing your patient to be on the herbal therapies for months upon months, you need to start thinking that you need to start switching your therapies from just the herbal antibiotics to complementing them with other treatments, whether it be with antibiotic treatments or elemental diets. But you need to start looking at something else because it shouldn't. Most treatments with SIBO are around 2 to 4 weeks, and that's the maximum efficacy pretty much of all the different therapies that I'll be talking about today. After 2 or 4 weeks, the outcomes really don't improve much. Statistically, not very much at all. Not worth the cost of the products for the patients, the hassle of performing them, and also the possible dangers for changing their immune and microbiome balance too much. Now, the difference between a hydrogen-dominant SIBO versus a methane-dominant SIBO is that we provide the same protocol, except we add in the allicin product. Allicin is an active ingredient in oregano oil, and it's a very potent product. It doesn't contain fibers. Just get a strict allicin containing product. It has no fibers of garlic, which the fibers of garlic could feed SIBO. And I myself had for many years used a freeze-dried garlic, and when I switched over to just the allicin, my patients let me know that they definitely noticed an improvement in the treatment outcomes. And of course, we see that on a regular basis. So when it comes to published efficacy for herbs, there is actually a nice publication. The overall research article is quite faulted. It was a comparison of the herbal therapies against Rifaximin, the preferred antibiotic treatment. But one thing to note was that the dosing of the Rifaximin was not the standard normal levels that we use today. It was about half the treatment dose. Less than half the treatment dose. And so I kind of ignore that whole aspect of the treatment protocol. But in the protocol, or in the published article, it talked about how during a 4-week treatment period, the herbal treatments were about 54.1%. And then when you included the crossovers from antibiotic treatments, it actually overall treatment rates went up to about 57%. And that's a reasonably very good treatment outcome for SIBO with somewhat minimal dangers associated with it. So herbals not having as many not having as many side effects as prescriptive antibiotics might not they therefore have some really good effect. In addition to that, one thing to note is that not only are you looking at knocking out SIBO and the intestinal bacteria with the herbal antibiotics, the other important thing to remember is that SIFO, small intestinal fungal overgrowth, occurs with SIBO 70% of the time. And in the cases where patients might not be SIBO positive, 20% of those times it could be SIFO as a main problem. Now, that is a really important thing, and this is one of the reasons why in herbal, I always recommend starting all SIBO protocols out with a round of herbal antibiotics because 1, you're going to be able to knock out some of the bacteria right off the bat. Number 2, they're herbs, so you're going to be able to adjust the dosing. You don't have to keep it at the highest dose possible. So I would tell patients right off the bat, hey, this doesn't have to be a sprint. If you can tolerate the herbs and we can be at a high treatment dose for 2 weeks or 4 weeks, great. But if it takes you 2 weeks to slowly ramp up to a treatment dose, well, that's great too. We don't have to run through this. We want to make sure we work with you and your body. So with that much said, in addition to the killing off the SIBO, those herbal antibiotics are also very good antifungals. So it kills off the candida in there, so it helps reduce side effects for the next round of treatments if you use next rounds, including both prescriptive antibiotics and elemental diets. Herbal antibiotics have been seen to be as effective, with the little asterisks for that published study that I just discussed. I do recommend taking them both before and after any elemental or antibiotic regime. So at minimum 2 weeks to up to 4 weeks for any pre-treatment. And then in the post-treatment, I just usually have patients finish up what they had left over from the pre-treatment so that they use up their products. I always tell them that they're not going to get better with time, and it gives them a little extra protection as they start expanding that diet again. Keys: proper dosing and duration. Many people are put on good stuff, but there's not potent enough to make an impact. And duration-wise, should be effective in short. If it's taken, you need to start looking at maybe some other alternatives. You have to use the garlic or the allicin ingredient for methane-dominant SIBOs. And of course, you always want to consider the root causes behind it. A little highlight on a couple of different other products here. The Neem is a strong antibacterial and antimicrobial. It's used both internally and externally for many different conditions. It's most well known in the Western world for acne treatments, but historically had been consumed after meals in India for gas and bloating. It's antifungal, and it also has anti-inflammatory properties. It's a wonderful product overall, and it's relatively very low cost, so it's the add-on for patients. Berberines are antimicrobials. I dose them 1 gram, 500 milligrams, 2 caps twice daily. Some practitioners go up to 5 grams daily. I don't do that, and I haven't seen much of a difference, but I do know that when you get to the 5 gram levels with berberines, you definitely increase the side effects with patients or the intolerance with them. If once again, that's just my own preference, but usually I'm at around 2 daily, but people are using it up to 5 grams daily. I just wanted to share that with you. They are generally at 2 grams a day, tolerated by just about everybody. Berberines also have effectiveness at reducing bad lipids and improving blood sugars. So sometimes it's a product that you start using maybe with SIBO, but you may use it long term at about 500 milligrams TID 3 times a day for LDLs and blood sugars. Berberines, when it comes to SIBO, they're not effective by themselves. Always add them to other herbs, especially something like oregano oil. Essential oils are the most potent antimicrobials pretty much on the planet. It's not as effective as essential oil drops. You need to have them in some type of capsule, and the gel caps or the concentrated capsules tend to be the better products. Many patients say that they use essential oil drops, maybe a drop or two. You know, a drop or two is going to be about 1 to 4 milligrams, and you usually need to have a treatment dose for about 100 milligrams. And obviously, if you try to drop essential oil directly in your mouth at that dose, you'll just burn your mouth and your esophagus. So we recommend not doing that. 2 caps twice daily, 100 milligrams, 200 milligrams twice daily, for 4 to 6 weeks if you're using it as just an herbal therapy alone. Minimum 2 weeks before any type of prescriptive or elemental diet. Consider pulsing every 2 weeks if the patient becomes sensitive. So, you know, if you're using an essential oil product, and I use a product it's a gel cap, and so that gel cap opens upstream with people, and if they have a mucosa that's a little irritated, if their mucosal line is a little eroded, or if they are a little more sensitive to chemicals, especially if their stomach's a little weak, they oftentimes can become irritated to this oregano oil. That's when I usually then switch over to an enteric-coated version so that we can drop the essential oil past the first part of the small intestine and have it open up and be used in the lower GI tract, which is usually a good strategy anyway to make sure that you're getting the proper levels of antimicrobials into all parts of the small intestine. And this is one of the reasons why a lot of patients, they sometimes never get better using herbal treatments alone. Sometimes they require an elemental or prescriptive antibiotic, and that's because, hey, your small intestines is 18 to 22 feet long, and when you're down 18 to 22 feet, most things that you just swallowed are going to be highly dilute by the time it's there, and so you don't get that treatment efficacy by using non-enteric coated products sometimes, and or just using the oregano or herbals. Now the oregano oil treats both SIBO and SIFO, so it definitely doesn't discriminate on what it wants to kill. It likes to kill lots of things. Commonly found in a lot of synergistic formulas, so you can find it. Just make sure it's about 100 milligrams per cap, or at least 200 milligrams per serving when you treat it. That seems to be the minimum dose that I find to be effective across the board. And also be warned, it's oftentimes the butt kicker. So when you add that into your treatment protocol, let people know if they're a little sensitive or if they seem to react to a lot of things or they're susceptible to die-off. Start with loads, just one capsule, lowest possible dose, and let them increase gradually so as not to shock them too much. And then allicin. Allicin is that active ingredient in garlic that's antimicrobial. We usually use a product that's about 360 milligrams of allicin per cap, and I use that one cap twice daily. There are very well-known products on the market that are about 480 milligrams per cap now, and you can use those twice daily too. I've never really seen a restriction on how much you can use. It can be a little caustic to people. It could also cause some really good die-off, so be aware of that. Allicin is essential if you have a methane-dominant SIBO. If you have methane SIBO and you're not using allicin, there's a good chance your treatments won't be as effective as they would be if they included it. There is a liquid available for children. It addresses both the SIBO methane-dominant SIBO, but it also is very effective for SIFO, small intestinal fungal overgrowth also. It does. If you just make sure when you look at one thing, look at your product. If it says, "Hey, it's garlic and it's standardized to allicin," that's not an allicin, straight allicin product. That means that there is garlic fiber in there. So check your labels. Make sure it just says allicin, and it is substantially more effective than just straight garlic or even freeze-dried garlic. So let's talk about prescriptive antibiotics. Now, remember, published studies show herbal treatments are about 54 to 47% effective. Patient compliance always must be factored in identifying whether or not you want someone to be using the antibiotic treatments, and you must always weigh the benefits over the harm for using them. Obviously, we by using herbal treatments before any type of prescriptive treatments, we always stack odds in patients' favor. And when it comes to treatments with antibiotics, we may seem a little bit aggressive to some people, but it's all about stacking the odds. If a person is going to go through and use antibiotics, well, let's use them for the shortest amount of time with the most amount of efficacy. And with that much said, the treatment protocol that I use is we use the Rifaximin antibiotic, which is known as Xifaxan trade name. It comes standard in a 550 milligram for adults. We use that 3 times a day. Typically, it's a 2-week to 4-week treatment protocol, and I'll just tell you right honestly, very few people, or I should say most people, will not be fully treated after 14 days, and most people will have a quick relapse with only a 14-day treatment. At my clinic, I, for the most part, only do a 4-week treatment protocol with Rifaximin, and sometimes that's a hassle, especially if you're using insurance. Insurance oftentimes likes to make sure that you use it only 14 days, and sometimes they have a time limit for when they can have a re-up on their script. So you might need to adjust patient visits accordingly for prescribing purposes. We also use for patients Rifaximin 3 times a day with metronidazole 500 milligrams twice a day for 14 days. We add, so this right here is pretty much our standard protocol for just a hydrogen-based SIBO. And that would I usually put them on 28 days of rifaximin, and the second 2-week period I add in metronidazole for 2 weeks. This provides the most efficient way to treating patients, and I'll talk a little bit more about the combination of that shortly. If the person is got methane dominant SIBO, we will use the rifaximin 550 3 times a day along with neomycin in first 2 weeks, and that's very important. Whenever we treat patients with antibiotics, we always use Saccharomyces boulardii during the daytime when they're taking the antibiotics. In addition to that, we'll use a probiotic at nighttime just to make sure that we're not having any extra damage from the antibiotics. So rifaximin is a patented antibiotic. It's a somewhat newer antibiotic. It was specifically designed to not be absorbed in the small intestine. So 97% of it will make its way through the body. Only 3% will be absorbed systemically, which then gives you an incredible safety rating. In the meta-analysis study of 32 different studies with about 1,331 patients, it showed effectiveness of over 70% with only about 4.6% adverse events. And so we're looking at extremely low negative side effects, and these adverse events were not major ones, they were rather minor. Rifaximin SIBO eradication successes vary widely due to study size and design, and I have found that, of course, if you just put your faith in just rifaximin alone, you are destined for lower treatment outcome or less outcomes. Neomycin is added along with rifaximin to greatly improve your outcome in treating methane-dominant SIBO. In a Pimental study, he's found that if you used rifaximin, neomycin alone, you get a 63% treatment rate. Rifaximin alone is a 56% treatment rate. If you add them together, you actually get an 85% treatment rate. And that's a huge difference between treatment rates. And standard protocol that integrative docs will, and SIBO minded docs will perform. Unfortunately, in the conventional world, oftentimes it's a difficult thing to convince someone to jump into because it's not part of the standard protocol in most clinics. And so it's something that you need to ask and demand. And I have had many patients who did not do their neomycin, and they ended up using up all their nice rifaximin and having their SIBO only partially treated or have it return. There are other anaerobic specific treatment protocols using clindamycin and metronidazole, and these are not good by themselves but can be added into other treatments because they do sometimes help those, and I'll talk about that a little bit later. Caution with antibiotic usage. Obviously, using antibiotics for up to 4 weeks in some people with a lot of GI issues, it can lead to some C. diff issues. So keep an eye open for that, and just always be wary that, hey, if the patient is very sick, very weak, that you need to make sure you monitor them closely. The treatment protocol that I've put together that I find to be about 92% effective includes rifaximin for 14 days. And if they're methane dominant, I use the rifaximin along with the neomycin. Neomycin 500 milligrams twice a day for 14 days, and the rifaximin 550 milligrams 3 times a day overall for 28 days. But in the first 14 days, for methane dominant and the first 14 days for hydrogen dominant. The second 14 days, I typically will use Rifaximin 3 times a day. Along then, I swap out the Neomycin or I add in the metronidazole, 550 milligrams twice a day for 14 days. And this is very important to do. I find you adding in Flagyl for that last 2 weeks does a couple things. One, metronidazole, which is known as Flagyl, has been shown in research to be the best at treating rifaximin-resistant SIBO, so we add it in there. Number two, it's very effective at helping killing off some parasites in the colon. Three, it is the preferred first-round treatment for C. diff. And so not only are you improving your outcomes, and it could be up to about 10% improvement in your outcomes by adding in the metronidazole, but you also avoid the C. diff, or at least minimize any possibilities of C. diff. And of course, if you see lots of patients, that just becomes a possible probability issue. And the final thing is that oftentimes you get treatments with metronidazole for things going on in the colon or that you did not even know were going on. And so you get some extra benefit. Likewise, the patients are treated most effectively. And this is just in our treatment algorithm. I just kind of highlight for more complex cases, performing the 2 to 4 week herbal treatments, the 2 to 4 week prescriptive treatments, and then following up with the herbal treatments are an ideal approach for a lot of patients. This usually gets me, like I said, about a 92% efficacy rate that we see with patients in my own practice. So Prokinetics may be needed, and I could do a whole entire lecture on just Prokinetics. We're not going to spend too much time on this. Prokinetics, if you read everything online or listen to every single SIBO expert, many people will say that you have to add in Prokinetics at the very start. I do not see that happening. I see that about half the time, if not maybe only 25% of the time, I need to add in a Prokinetic. If you think no one will ever get their movements normalized after a successful SIBO treatment, you are horribly wrong. Many patients' bowels become more normalized when SIBO is properly treated and may need to be maintained one way or another. Now, granted, I don't like using laxatives to maintain them, but if I'm able to maintain it by healing their gut further or providing digestive enzymes or modifying their diet, these are possible root causes behind why they got the SIBO in the first place. So they might not, most people won't, many people won't need a Prokinetic, so start SIBO treatment first and about halfway through treatment, reassess whether or not you think a Prokinetic is needed. And so I do that around halfway through treatment protocol. When it comes to prescriptive Prokinetics, we look at low-dose erythromycin, low-dose naltrexone, and even mirtazapine, the Remron. Now, I use Remron only in cases where we have swallowing issues or more severe upper GI issues that are not associated with SIBO. And I try not to use it. Oftentimes, though, it's a short-term treatment and could actually have some major implications in helping people who might have been falsely diagnosed with anorexia or other issues due to the pains associated with swallowing or the inability to empty their stomachs. But historically, now there's a published study using low-dose naltrexone with SIBO patients and showing it being effective. I honestly just never seen it be effective. Maybe I just haven't done it with enough patients. I thought I gave it a pretty good population size to trial. I just never really seen it that effective. I do find erythromycin 50 milligrams at bedtime to be effective. When some patients want the lower cost way, so not going through a compounding pharmacy, but to take the 250 milligram wafer and then crack it in half and swallow it, I strongly urge people not to do that. Because that oftentimes leads to a caustic burden of the gastric tissues. erythromycin is very acidic, and when you crack that tablet in half, you take the buffering off of it, and you can easily cause an ulcer in a patient. So I strongly urge people not to do that. Natural options for prokinetics include ginger, 5-HTP to make serotonin, general amino acid support, which includes not only 5-HTP, and there's some proprietary botanical formulations, sort of like the iberogast and whatnot. Unfortunately, those aren't even available anymore. Ginger has been researched to be taken about twice a day for its prokinetic effects. It's found synergistically with other ingredients like ginseng and peppermint, which also have some very good benefits. It's also known as a good anti-inflammatory. So it's a nice ingredient to add in either by itself or with a synergistic formulation to help with people both as an anti-inflammatory and as a treatment protocol as a prokinetic. Serotonin support. 50 milligrams to 100 milligrams twice or 3 times a day is a typical dose that oftentimes, if it works rather quickly to help start boosting serotonin activity. The low serotonin activity has been shown to occur in IBS, and depression, insomnia, anxiety, hot flashes, and headaches. So if you have a SIBO and you have headaches all the time, you should have low serotonin activity high on your list. We at our clinic, we use urinary neurotransmitter testing performed by a mass spec laboratories, and we find them to be extremely useful, especially when it comes to serotonin, because serotonin activity in the urine reflects that throughout the whole body, including the brain, rather closely. Other neurotransmitters, maybe not so, but likewise, they're very effective to measure activity level and then to help in customizing some protocols, because we've seen many people with gastroparesis where not only is serotonin low, but overall all their catecholamines might be shot too. Well, kind of difficult to get a nervous system to work if there's no fuel for the nervous system. And that's where oftentimes amino acid therapy can come in handy. Other things outside of just prokinetics by themselves, using betaine hydrochloric acid, pancreatic digestive enzymes, and ox bile can all be used. I strongly recommend trying one at a time, not all of them at once, because you don't know which one you need or which one's the most effective. Someone had asked about betaine hydrochloric acid challenge test. That is an easy test where you have a patient start with 1 capsule of betaine hydrochloric acid. Those are usually commercially found to be about between 500 and 750 milligrams per capsule, usually betaine HCl along with some other ingredients. And you start with 1 cap before a meal. If they don't get any type of tummy warmth or heartburn feeling, then you increase to 2 caps. And likewise, you keep doing that up to what I have is a maximum 4 caps a day, 4 caps before a meal. If they are taking 4 caps and not getting any type of warmth in the tummy or heartburning like feel, then they're not making any hydrochloric acid. I do not keep them at 4 caps of betaine HCl before each meal. The max dose I ever do is 3 caps, and that is because there's only so much HCl your stomach is supposed to make, and if you take too much, you can very well start causing problems. Your stomach does not normally feel acid in there unless it's too high, and for some people, they might have very thick mucosal linings. They might not notice it. I've seen patients whose practitioners have told them to go up to 7 caps a day or 7 caps before a meal, and I find that horribly setting them up for possible gastric erosion and side effects. So we just max that at 3 caps. And there's lots of documents. You can probably find someone's patient description on how to perform that online. Pancreatic digestive enzymes, these are much more popular than putting people on just ox bile, but I will always do ox bile second. In the case of SIBO, many patients are hypochlorhydric. Those that are not oftentimes have fat absorption issues and or decrease bile secretion, which then sets them up for possible repeat issues with SIBO. Finally, I do pancreatic enzymes third. Once again, in just the order of how effective they are, I just see that the HCl is more of an issue, the ox bile a close second, pancreatic enzymes actually a distant third. Gut motility and thyroid, once again, it's not often properly diagnosed with people. You need to do a free T3, free T4, a TSH. Look at antibodies. Someone can have very low normal hormone levels, but have elevated antibodies, and that leads them into a possible subclinical hypothyroidism. So you got to look at it because it's such a major issue when it comes to gut motility still in 2018. Oftentimes, hypothyroidism can cause constipation, decreased taste sensation, gastric atrophy, and edema. All these things that also can be caused by SIBO or worsen with SIBO. And just as a little side note, pernicious anemia occurs in 10% of all the people with autoimmune thyroiditis. So you have patients with Hashimoto's, well, 1 out of 10 of them is going to have pernicious anemia. If you don't have B12, you're not going to have an enteric nervous system that works, you're not going to have healthy tissues, and then you have a domino effect, once again, resulting in maybe chronic SIBO. Gut healing, important to improve the gut barrier after treatments. Sensitive patients may require gut support all throughout treatment, like an L-Glutamine or other things. You could also look to do some screening tests on their gut healing. Look at their IgG food sensitivities, their myeloperoxidase, elevated total IgEs. Look at their total IgG, IgA levels. These and a CBC with differential, all things that you can take a look at, because you can have a gut tissue compromised for a lot of reasons, SIBO being one of them. You can have other things going on that where the SIBO worsens it, and or they actually worsen the whole system and then cause a SIBO. So it's always important to do a little extra healing or little insight on testing wise, not to just assume leaky guts must be present because they have SIBO. Clinical Pearl, start with some simple and non-fibrous therapies initially, like an L-Glutamine powder. SIBO can grow with many fibers and prebiotics, so be careful when you do start prescribing things to help with their microflora. Root causes of intestinal permeability is typically SIBO, and once gone, it can usually heal. But you know what? They can have other problems. So you might need to do comprehensive stool tests afterwards, food sensitivity testing after SIBO treatments to get to maybe the main culprit. L-Glutamine powder, this is one of the things that I've used throughout my entire career. We don't really normally see urinary glutamate levels increase with it, and we do lots of neurotransmitter testing, so it's I'm not saying that it can't happen. It's just that if you looked at the biochem pathway, you just think that glutamine has to be turned to glutamate, and it doesn't have to be. It's used for a lot of things, and glutamate's only an issue when glutamate is circulating at extremely high levels, and it's affecting the central nervous system. Not that we like glutamate, it's a something to control in a lot of these patients. But 6 to 7 grams of L-Glutamine powder is usually the dose we do twice a day for 1 to 2 months. And that provides a really good basis for healing tissues. For many patients, we use it as a first-line treatment for constipation. It's great in children because if you're really constipated, you can start L-Glutamine, and there's a good 30 to 40% of people that have improved in bowel movements just with that. And likewise, L-Glutamine powder could actually help in removing ammonia levels, which are often elevated with SIBO. Vitamin A, we dose it at 20 to 25,000 daily for 1 to 2 months. And acetylcysteine could also be used. It could be used as a way to help break up some intestinal biofilms. It's been shown to increase intracellular levels of glutamate. It's also an anti-inflammatory and antioxidant. I usually dose it pretty high, 1 milligram 3 to 4 times a day. And it is a little synergistic, so if you have someone with OCD or anxiety, L-theanine and L-glutamine are good complements with it. So what treatments are you going to choose for your patient? What are some of the contradictions to think about? Contraindications, to think about. Patient preferences and severity, location, treatment, and medical history are all things you want to put in place because, once again, we know there's 3 main treatment options for SIBO. All right, well, if they have eating disorders, if they're really low in body weight, well, a 2-week liquid elemental diet is probably not a good option. If they've had many cases of C. diff, antibiotics are probably not a good option. What about patient preferences? Some patients never want to use another antibiotic the rest of their life because they got so ill with them, from them. Great, that helps you identify what they would like to use. Some patients never want to go on a restricted diet. So, all right, well, elemental diet might not be a very good choice. Likewise, severity and location. If most of the growth is 18 to 22 feet down, well, it's going to be really hard to treat with just herbs alone. You're going to have to either starve it off with elemental, treat it with an antibiotic, or maybe do both. And likewise, in medical history, well, what other treatments have they had? I've had patients where they've gone through multiple rounds of antibiotics, herbals, and elementals, and they still had SIBO. So we ended up saying, well, great, we're going to try an experimental fourth option, and in those cases, we treat with live probiotics. So here's a couple, a few quick summaries of some different ways that we address patients with SIBO treatments. This is an example of a patient with a hydrogen positive SIBO, and most of it's in that lower small intestine. So here it is. At 100 minutes, 120 minutes, their total gas levels jumped up dramatically. They became easily SIBO positive in that time period. Well, that's a pretty far way down. Just as a reminder, when you're 18 to 22 feet down in the small intestine, herbs will lose potency as they go make their way downstream. So look to do a combination of gel caps and enteric-coated gel caps for the oregano oil. That's where I usually use product for 2 weeks and then switch over to another one, because if you're using a traditional capsule or gel cap, that oregano oil is going to be really potent in that first part of the small intestine. But if you use an enteric-coated product for the second 2 weeks, you'll actually get more potency of the therapeutic herb in that lower small intestine. Follow-up treatments can be either the elemental or prescriptive antibiotic in cases like this, depending on how they respond and how they and whether or not you want to retest to confirm that or not. This is a patient with a severe methane dominant SIBO, extremely elevated methane from start to go. Yeah, they increased. It was anything greater than 10 parts per million of methane is a positive. This person was lights out, horribly positive. They had severe SIBO activity. We did the herbal to the elemental. We monitored for fatigue, and then we eventually used the a SIBO protocol to treat them with. Well, I'm sorry. Your options would be to do the herbs to the elemental, and also the treatment of the SIBO protocol using the herbs to the antibiotics. In this particular patient of mine, I actually chose this because the patient was not able to even consider the elemental diet due to the illness and pain that they had. Many other patients that we've had with lots of chronic pain actually choose the elemental diet because it's actually a little bit easier for them. Methane dominant SIBO affecting the entire GI tract. This is where it was elevated all throughout. Once again, this is an example of a patient with lifelong constipation. They preferred to avoid antibiotics, so we did the herbal treatments for a total of 6 weeks. And I know I talked about how I like to keep it between 2 and 4 weeks, but because of how long this has been going on, I thought once again I wanted to stack the odds in the patient's favor as much as possible. So we did a maximum 6-week herbal treatment, followed then by a 2-week elemental diet. Halfway through the treatment, we reassessed to see how the bowels were. They were not moving yet, so we added in a prokinetic, and that actually helped quite a bit for that patient. This is a patient where they had only a slight increase in SIBO activity. So they barely got a positive. You know, they reached a combined sum of hydrogen and methane by the hair of its chin. And so I kind of diagnosed them that it was more of a dysbiosis than an infection. So because the location's all in the lower GI tract, we did a 2-week enteric-coated essential oil product with allicin, because the methane level was about 5 parts per million at that 120-minute mark, which is a little high, about as high as I really like to see it. We followed it then by a 2-week live liquid live probiotic, 4 to 5 times a day for 2 weeks, and they actually improved greatly with the treatment protocol. Here's my last case study. This is a 54. This is my second to last case study. This is a third to last case study. This is a 54-year-old patient, post-Lyme treatment syndrome with burning mouth, esophagus, no diarrhea or constipation, but he had gas with most meals. 12 months on antibiotics to address a tick-borne illness sure helped his life out a lot, but then he had a burning mouth syndrome that started with the disease that continued and got worse. And of course, he has extreme fatigue and pain. First treatments for SIBO were done, were just for Rifaximin, and he actually had success, actually some of the symptoms. So he came to see us, and we retreated him, and actually had a little more improvement. During that second round of treatments, we kind of figured out that his symptoms started manifesting more like babesia, so he returned back to treatment for babesiosis. 16-year-old female with chronic insomnia and anxiety as the main issue, but she's had lifelong constipation, or abdominal pains, and a history of bulimia and food aversions. She had done an IgG food sensitivity test with us initially, which made her extremely positive on all the usual suspects, showing to us a leaky gut-like syndrome, a multiple sensitivity. She went on the restricted diet, and she did better for a while, but then her symptoms came back. We tested her for SIBO, and she was extremely high in methane. She did not tolerate the herbs very well. Her gastroenterologist saw everything that we did, agreed to use Rifaximin, but only Rifaximin, not Neomycin, and only gave her a 2-week script. She felt better for 2 weeks, and then her symptoms came back actually worse. Insomnia, anxiety stopped then after I put her on my protocol of the Rifaximin with Neomycin, followed by Rifaximin and metronidazole, and she did much better for a very long time. 41-year-old female with chronic interstitial cystitis, insomnia, constipation, severe fatigue, brain fog. This was a person who did extremely well with just a SIBO protocol using the herbs to the antibiotics, and kept on a somewhat restricted diet. Last case study is a 54-year-old female with persistent SIBO, main complaint of chronic insomnia, wakes up at 3 a.m. Every day, feeling over-caffeinated, side effects with most drugs, constipation with berberines, headaches with digestive enzymes, you name it. So she had started being tested and treated by another person. So they had originally done June 2015, they did herbal antibiotics for extremely high methane SIBO. It was too few herbals, too low of dosing, so it was a pretty somewhat poor outcome also. In 2015, she came to see me. We diagnosed her once again with SIBO with methane, not as high as before, but still pretty high. We treated her with herbal and then prescriptive antibiotics using the Bush protocol, and she was sleeping better for 3 months and then worse again. Retested her, and she ended up being very bad in methane SIBO. So then I said, hey, sorry about it, but you need to start the elemental diet. So we did the elemental diet, and she didn't want to do the elemental diet because of the worry that muscle tone and fatigue would occur. She was an actress and didn't want to have her professional career suffer a little bit, but she ended up doing it, and when she retested, her levels were wonderful. Still slightly high in the methane, but nothing like it had been done before, and she was sleep better with no bloating and good energy. So we had to do a little bit of good probiotics and other things to support her. So hey, that was a lot of information in a short period of time. I look forward to answering any questions that people might have at the end of this, and likewise, we'll probably sign off, and then I'll probably email responses to anybody, because I ran over a little bit. But if you're interested in testing SIBO, feel free you can set up an account. In order to order a test for a patient, you just set up an account, fax in a requisition form, and then we'll process an order within that day. Patients receive in the mail the collection kits along with instructions and patient intake form. We only use Quintron branded easy sampler home collection kits, which is what all the researchers and hospitals use. And so that's why we drop ship the materials to the patient. And then when they complete the test, they'll come back to us, we'll run it. If you need any help with interpretation or with treatments, or you have any difficult patients, feel free. We have complementary support services with our 2 SIBO doctors, myself and my wonderful wife, Rebecca, who's also one of the owners of Neurovanna. Speak with practicing. We're happy to walk through all of your first reports and any type of confusing patients. We've seen a lot of different ones. So in conclusion, SIBO is a challenging and complex clinical condition with etiology typically multifactorial, symptoms often misdiagnosed. Treatments include antimicrobials, herbals, elemental diets, dietary restrictions, nutrient depletions, gut barrier support, root cause issues, and even prescriptive antibiotics. Not every patient responds the same way to each treatment, and some patients will require multiple rounds or alternative approaches. So don't treat it like it has to fit within an easy protocol. Sometimes you have to fit your protocol around unique and difficult patients. Hey, any questions? This is how you can get a hold of me. You can email me at the clinical support at neurovanna.com. And if you want any copies of the slides or the algorithm, feel free to contact our sales department. And that is going to be the conclusion of this webinar. I'd like to thank everyone for joining, and we appreciate you for being here. Please check out our website at www.neurovanna.com to review our recorded webinars that we have posted. If you need any help setting up an account or have additional questions, please contact our sales department or drop us an email. Thank you again for joining us, and we will see you next time in our next webinar series that is to be announced. You take care and have a wonderful rest of the week.